the recording option is with you, just to let you know, because this should be a recorded session for sharing with other people.
Yeah, I've just done that.
Okay, thank you. So I hope everyone is here with us and is excited to be part of the session. Last week we had an encouraging session, and I believe it was a good one. When we were looking about the mental health task force report, we had a review of that. And then beyond the task force report, we went into the health amendment laws. And in terms of the health amendment laws, there were key issues that were addressed. And people are excited, people are looking at ways they could chip in and support that and find a way that at the end of the day, we'll have a responsive. Somebody's saying there's no sound. Can you guys hear me? Maybe you could just confirm on the chat box. Let's get comments on the chat box for people who can hear. Perfect, thank you so much, guys. So I think the guy with the Galaxy A20s, you could just check your login options if it's possible. Probably you didn't join by the device audio, so that should help you get through with it. So thank you so much. So with that said, today we are looking at it in terms of, we have a change in the current situation. COVID-19 has come into space. It started in 2019 in Wuhan, China, and then coming to Kenya, we had the first case on 13th March. And there have been an evolution of the things that are happening in our landscape. And there are issues that have arisen. Some are better, good for us, some are not good for us. But at the end of the day, we have to find a way. What's the coping mechanism? So that's one of the first discussion that we'll be having today. Then after that, we'll move into the second session, which will be the US-Kenya free trade area trade negotiations that are there. What's there for health? And the question would be, what is there for health in terms of ensuring we have robust healthcare systems? And beyond that, what's there for us as individuals to play our role in ensuring we have a responsive healthcare system that's going to leverage on such kind of free trade negotiations that are coming? Because you realize most of the free trade area trade negotiations that have been in place, most of the health concerns have never been factored as much. But now this is a time that it's happening. We are in the middle of a pandemic, and there are options that we have to leverage on to ensure beyond this situation where we are riding on the wave of the current trade negotiation that is underway. We are going to have a responsive healthcare system. We are going to get measures and ways that we can use it to ensure we cushion our health systems, we improve on our healthcare delivery models, and ensure we have a responsive health system at the end of the day. So as you're going to start into the session, before I start the presentation, Hezron, I'll request that you share the poll that we have. The next one.
Are you able to see it now?
Yes, the next one. This was from the last session that we had last week.
Okay, sorry.
So let's have people respond to the first one first. So as we're looking at it, COVID-19 as a make or a breaker, you look at it in terms of, has it made any positive impacts in your life, in the lives of people you have interacted with, or has it not made that impact? Or has it made things worse for you, for the people around you? And yeah, that is the overall scope around that. Then the second question is straightforward. The third question, you'll answer that at the end of the session, so you don't need to answer it now. So let's say you can give it a minute or two. Then we'll close the poll. And Hez will share with us the poll results.
So 36% of you have done it. Please continue voting. We are at 50% now. Please vote.
Just a comment for the people who have not marked the last one, you can just mark no for the start, then we'll relaunch the poll again, because you can't submit before you mark the last section as well. So as you can share the poll results.
Okay, sharing right now.
So assuming everyone has voted and we are 14 in the chat room, so I could say 13% feel it's a makeup, 13% it's a breaker, 50% both a maker and a breaker, 25% are conflicted around the whole situation. Then this is a tie. 50% have heard about the US-Kenya free trade area, and then 50% have also not heard about it. For the other question, that one will launch again and look at it in the subsequent section of it. So thank you guys for the responses. And this is going to give us a guide in terms of how are we going to look at the impact of COVID-19 in our current circumstances. What are the challenges we've had? What would be the ideal response mechanism, if there is an ideal one? In case of a pandemic or disease outbreak, there's never any clear roadmap on how to respond to it. But at the end of the day, in terms of responses that have been put in place in the previous pandemics, we can consider Ebola in West Africa, we can consider the SARS virus, we have MERS, Middle East Respiratory Syndrome, and even the Spanish fever flu that was 1918. Those are kind of guides that we can put in place, and looking at it according to the current existing frameworks on disaster risk reduction, DRR, disaster risk reduction, then we look at it in terms of how do we cope with this situation. So looking at COVID-19, the background that we have in place is the first case was reported on 29th December 2019 in Wuhan, China. Then in Kenya, the first case was reported on 13th of March, was a Friday. Then COVID-19 as itself, it's a viral disease, coronavirus disease that was discovered in 2019. So that's the acronym for the name COVID-19. Transmitted through contact with contaminated respiratory droplets and body fluids. So that is the main mechanism of transmission. And that is guiding us in terms of what are the control measures to prevent transmission of the viral particles and to flatten the curve of transmission, that is. Then beyond knowing that, it's also going to guide us. Being a viral disease, we understand that from the scientific component, viruses have no cure. Instead, this is because they normally rely on the human cell mechanisms for replication and for propagation. So it relies on your cell. For it to be cured, we have to kill it. We can't kill a virus if it's using your cell. The best we can do is find a way to reduce its replication and all that, and that is the mechanism. So as at this moment, there's no proven cure or vaccine for COVID-19. However, as you guys have mentioned, we have the impact on health, social factors, economic impact of COVID-19. It has been high in certain situations, whether positive or the negative. There are people who have reaped out of it. There are people who have been devastated by the COVID-19. And at the end of the day, we are with it, we live with it, and we move past it. So looking at the Kenyan response, these are the kind of situations that we had. Well, the first thing that was done on 15th March, the first disease outbreak, the first case was reported on 15th March, was a Friday. On Sunday, the president gave the first presidential address on COVID-19. Travel restrictions were outlined by the president. Schools closures were recommended to be done by 20th of March, the following week on Friday. There was a call center that was established for reporting and communication of COVID-related matters. That was 719. Religious gathering was stopped because there was a risk of transmission when people are in higher, large groups of people. The social distancing measures were coming into place. Then based on the assessed economic impact, there was a tax relief for anybody earning less than 24,000 Kenya shillings. And for people earning above 24,000 shillings, there was a waiver of 25% tax other than the recommended pay as you earn of 30%. The VAT rates were tapered down from the actual 16% that we had in place to 14%. And those were to run for a period of 3 months. Then, realizing there was a shortfall in terms of healthcare workers, the government recommended appropriation of 1 billion Kenya shillings for employment of healthcare workers. And for employment of healthcare workers, that money was to be drawn from the Universal Healthcare Coverage Kitty. As you guys can acknowledge, the UHC Kitty was established following the launch of the Big Four agenda in 2017, following re-election of His Excellency President Uhuru Kenyatta. That is $1 billion that was to employ healthcare workers. So those are some of the steps that were taken. The subsequent follow-up, there was a curfew that was running from 7 p.m. to 5 a.m. that was instituted on 25th March, partial lockdown or cessation of movement in and out of the Nairobi metropolitan area that covers up to Thika, Kiambu County, Mombasa, Kilifi, and Kwale counties. Those were the counties that were affected. There was a revamp of local production of medical supplies. When I talk about revamped local production, we have companies that have been operating. But in the outset of COVID-19, medical supplies and even flights and transportation of cargo had been interrupted, affected in some way. And therefore, in this case, there was need to have local supplies. And then being a global pandemic, different countries were affected at the same time. And therefore, having access to the essential medical products and services would be a challenge. So in this case, there was the Rivertex being allowed to produce face masks and related PPEs, personal protective equipment. There was the Kitui Textile also producing the same. Pharmaceutical industries and production plants that were producing sanitizers, cleaning material, detergents and all, were given the authorization from the Pharmacy and Poisons Board in liaison with the Kenya Bureau of Standards, following scrutinization and standardized production of these materials to ensure we were able to meet our local needs. Then the lockdown was lifted now on 6th of July. That was on Monday last week, but one. So the lockdown, that is the cessation of movement between the different counties, that was lifted on 6th. The same time, the curfew was extended from the 7 p.m. to 5 a.m. to 9 p.m., 4 a.m. And those are the new measures. Then last week, this week that we are coming to an end, there is a mention of employment of Cuban doctors who are being imported, 20 of them, to help in addressing COVID-19. So that has been a mark of the normal Kenyan response as we have it at this particular point in time. Some I might not have highlighted, but I highlighted the key ones that I feel like are pointers in terms of how are we going to move forward and how are we going to ensure we have responsive healthcare systems. So in case of a pandemic, especially in terms of a health crisis as we have, there are key essentials that need to be looked into. As infection prevention and control measures, that spans communication of the infection, communication of the data, and accompanying that communication with capacity building. If I'm telling you to sanitize, I'm telling you to wash your hands to be safe, then it means at the end of the day, I should be able to enable you to wash your hands. If I'm telling you to buy a sanitizer, are you able to afford that sanitizer? So those are the accompanying measures in terms of infection prevention and control. There is emerging evidence about probable other routes of transmission of the virus. Are we looking into it? Then when we are doing it, how are we communicating to ensure we are flattening the curve by reducing the rates of transmission? That's one very critical one. Post communication, I mentioned 719, the toll-free line that was established for communication about COVID-19. Looking at it, it was for communication on anything, any concern, somebody having a symptom that they feel they might be infected with COVID-19. This was going to be the relay station for all concerns. So if that communication is already out there and you're able to access the services, then we need to accompany it with good parallel operational services. I'm telling you that you suspect you're COVID infected, call 719, they'll link you up with an ambulance service to take you from your house to reduce risk of any other transmission among the people you come into contact with as you're being taken to a hospital. That's what on the initial phases. Was it in place? You all can acknowledge that some of it had challenges, and even people with other health concerns, for example, pregnant women that needed to deliver, were not able in certain situations to get access to the ambulance services. So what's the impact at that point? It's a breaker because it's making people have to go through extra strain. Testing capacity. We had shortage in testing capacity. Test kits are not available, and even now we are still suffering from the same problem as a country. That's one. Two, beyond the testing aspect, communication is not linked with the good parallel operational services. Individuals are being encouraged to go for testing, yet you're going to get to be tested and we don't have the capacity. It means with 0 test kits, you are feeling like you're going to get tested, but there are no tests to be done, so it won't be done for you. What happens after that? You've traveled to the hospital or to the testing center, you are risking exposure one. When you come home, you are still risking exposure. When you get to the facility, you're not able to be tested. Do you trust the system that informed you about it? Do you think everybody will feel like the COVID-19, the coronavirus disease is in place? Maybe not, maybe yes. But what are we looking at? So those are some of the issues that we have. You get to a hospital, what is the hospital response plan? Do they have the ability to take care of you? For example, you are having cases where a doctor has died, a number of the medical workers are infected, and they're infected with COVID-19 because the concern that they have is there is a limited supply of personal protective equipment. So they're also risking their own lives in the line of work. So who would want to do that? How do we ensure that the medical workers are equipped to be able to attend to such cases? In clinical case management, symptom management, what are the clear guidelines on managing these symptoms? Are they documented? Are we doing research to ensure our responses are evidence-based? Healthcare workforce capacity, we're having shortfalls. The amount of money was appropriated to be used from UHC kitty to employ healthcare workers. How many have been employed? Where have they been deployed? How are they responding to the COVID-19? Have they been trained on personal donning and doffing of the PPEs? Have they been trained to respond to COVID-19 in those situations? If not, then we are not ensuring the clinical case management aspect of it is being attended the way it should be. Then care cascade, now we are having management from home. If you're managing a patient from home, COVID management at home, how do we align that care from, I'm sick, I'm at my house, I'm getting critical severe at some point, then I need to be taken to a hospital. How is it linked for me to get an ambulance service without risking infection of other people within my environment as I go to a hospital? And then when I'm in the hospital, the care being given will be optimal to ensure that I'm sustained, I'm kept alive. And if I'm going to die, how do we communicate that to the people, my family, the people who are taking care of me, and any other person who is involved in that care plan? So these are some of the essentials that we need to look at. Other health and allied health concerns. Mental health, psychologically, people are traumatized, people are stressed, and those are some of the factors we have. Maternal care. I mentioned a case of a lady not being able to access ambulance services without paying for it because every other focus was now on COVID-19. We are risking care. Non-communicable diseases. Chemo services for the cancer patient, they're not able to get chemo sessions. Reason, there's a risk of infection and already they are compromised in terms of their health status. These people are not able to access care. How do we ensure they have access to that care? Those are challenges. HIV/AIDS management. This is a problem that we've had. Initially, when UHC came into place from this year, from February, HIV/AIDS patients, as we all know, they are immunocompromised, and therefore it means they need to have a booster and prophylactic management, which comes through use of cotrimoxazole or Septrin, as you all know it. However, since February this year, these patients have not been able to get supplies of Septrin. When you asked about it, the reason is the government transferred the funding for Septrin, the cotrimoxazole, to UHC kitty in terms of universal healthcare coverage to cater for the needs. Yet these are vulnerable groups. Now they're going without drugs. Access to the actual drugs are also kind of, at times it's not that streamlined, and they're at more risk of COVID-19 and any other condition that might come around. How do we respond to them? Did we factor this in our response plan? Maybe, maybe not. And those are some of the things that we need to look into. Nutrition. People have been laid off from work. People are broke in their homes and all. These are factors that are affecting TB care. How do the TB patients access their care? Respiratory complications, very critical in terms of COVID-19 manifestation and the complications that are arising. So how do we respond to them? Health system capacity. Our leadership in the healthcare system. These are still the very concerns that we have. If you've been Twitter, it's here people asking why we would have Amoth, the acting director at MOH, still continue being in acting capacity rather than taking up the leadership and being the DG, Director General. Who are the leaders in our different health facilities? How are they responding to COVID-19? Do they build capacity in their people? The human resource component of health. Do we have adequate workforce? Now we're employing 20 from Cuban doctors. What extra qualifications do they put in place? How many unemployed Kenyan doctors do we have? If we can look at the statistics of what we've had from KMPDU the last time, there was over 1,300 trained medical doctors in the country who are unemployed. Currently, there are a number who are doing the internship, they're due to graduate as well. These will add into the number. Yet, they are unemployed and we are getting imported doctors. Not that, I'm not sure whether they have a way that they're treating COVID-19 other than what is already in practice, that's one. Two, there's no cure. And three, the cost of hiring these extra doctors would be actually exponentially higher compared to using the locally available human resources. How do we mitigate these kind of measures? Supplies of medical products and services. This is a very critical thing. I mentioned in the government response, we revamped local production, which is an amazing thing when we're having Rivertex and Kitui Textile producing now the personal protective equipment. But the question that lies at this point is, why would the government allow and authorize the production of these equipments from local companies? And then once they've authorized the production, instead of having KEMSA, the Kenya Medical Supplies Authority, buy directly from the industries and the companies that were producing them, instead, after confirming that they've been produced, they notify the public that now you can go buy from Rivertex and sell to KEMSA. Is that not having another bridge, another broker within the line? And when we have an extra broker in the business terms, the markups keep coming, the margins of interest. So at the end of the day, the government will be buying it at a higher cost, which would have been controlled if we just buy it both directly, and now the KEMSA done the supply chain model. Infrastructural capacity, the logistical supplies and all that, the hospital capacity in terms of ventilators, ICU beds, and that is a challenge that we are having. So when we look at all these, you realize that our initial response was adopted from developed countries with minimal contextualization. Why do I say this? One, when we realized there was COVID-19, borders were closed, which is okay because we are stopping any new transmissions, new infected individuals coming into the country, and us not also taking it out there, which is okay. Moving from there now, we are imposing lockdowns. What is the impact of COVID? What is the coping mechanism? We would look at it in this way. We have a case that has been reported. There is no cure. We can't take care of the individuals who are infected, but putting in a lockdown, what would be the impact of it? Some people are going to go broke, seriously broke, which is for a fact. Then beyond that, other conditions need to be managed. Do we have special treatment centers where they can have, like, for example, cancer patients who need chemo to continue accessing services from a different facility, which is specialized for that very critical condition? And alternative different other conditions as well. When we are looking at employing healthcare workers, who are the people we need? Which kind of response do they need to offer? It's not just a matter of getting people on the board because we need healthcare workers and we need to show the public that there's something happening. That something happening has to be accompanied by facts and measures from the ground on what needs to be done. So we need to contextualize it in terms of what are the challenges we have, what are the probable challenges that may arise from adopting this kind of a measure that has been recommended, and then how do we ensure it's accompanied by other services that are aligned to it to ensure it achieves the ultimate goal, the contextualization bit. Health and allied health concerns were not factored up front. This is another thing that just feeds into the contextualization. Over this period, we've heard about cases of teen pregnancies in the rise and all. Some of them might not be totally associated with COVID-19 because some of them were even reported in January. In January, we didn't have COVID-19. And there's been a scale all through up to this point in time. So did we factor these? Mental health services, the task force report is coming out and everything. What are the implications on all the other healthcare concerns that need to be factored. If we are not looking at these in terms of the social component of it and the overall human well-being metric, then we are not responding to COVID-19. We had a lockdown, the numbers have skyrocketed again. Now we have the lockdown has been lifted. So what's the next move? And in the process of that lockdown, people didn't have much to go on with. People have lost jobs, people have suffered more economic turmoil and all. The social anxiety, being separated from families because of the failure to travel from one location to the other, work from home measures. So all these have to be factored in terms of ensuring we have a robust system, a robust response mechanism that will ensure people can continue with their livelihoods. It's not like COVID will go away and then we resume our life as where we started and start afresh. We have to continue living in between. And how do we continue living? But we have to acknowledge we have to reduce our risk of transmission. We have to ensure that people who are sick get the care they need. And it's not like COVID-19 stopped every other disease. Other diseases have also to be taken care of. So how do we take care of them? Then health workforce capacity shortfalls, worsening cost on lives is rising. Healthcare workers are dying as well, some are getting infected. So those are issues that are there. Mismatched communication into care access, I mentioned that when I was looking at, for example, we're told to go for testing and the tests are not there. So these are very critical concerns that we have to look into. And the reason as to why all these insights that I'm sharing, it's not about hearsay or anything. Last week, but one, the day that the COVID rules lockdown was lifted, this is my personal account and what I went through. I stay in Kiambu County and I had to get an Uber and get the guy to take me to Mbagathi for testing because I suspected I had been infected. I work in a hospital. Nairobi. So in the process of traveling, I went to Mbagathi, 50 people. Being a healthcare worker, I had access to, I got a chance to be tested because of being a healthcare worker. But what about the others? We were told that only 20 people can get tested because the test containers were limited. So in that kind of a situation, 20 getting tested, we had over 50, it means 30 of them will not be tested and these people will go home. They risk coming, they're also going home again, they're at risk. Reason, there is a mismatch in communication. What they're being told to go for tests, it's not matched by accessing these services. We acknowledge that the services cannot be offered because globally there is a shortage of the testing materials. But why don't we acknowledge that and tell the public, we are not able to meet your need for tests. But at the end of the day, you have to take care of yourself. You have to avoid risk of infection. And in case you get infected, we have to boost our systems to ensure we are able to test at a particular level. But at the moment, we are not in a position so that we don't risk extra people being exposed by going for the tests that are not there. So that was my case. After that, I got my sample collected on Monday. I came back home and it took 4 days because that was on Monday and Thursday. That was the day my test results were coming out. In 4 days, that is 24 by 4, that is 96 hours. That is the day my test results came. In every daily report that we have about COVID-19, within the last 24 hours, we've recorded these. Within the last 24 hours, these are the recorded cases. Are they really within the last 24? If the day I was tested with the 20 that we were with, somebody tested positive, when were their findings reported? There is a backlog and we have to communicate, we have to let the public know, these are the people who have been tested. There was a delay in terms of their results coming out and these are the issues that are there. So these are some of the questions that the government needs to respond to. And unless we tell them what to do and how to go about it, it will never happen. So what's the way forward? We have to review our approach, adopt and assess cost and damage cost. That is the role of the government. I'm not with the government. But at the end of the day, we have to do something on our case. Acknowledge shortfall and establish systemic broad angle approach to ensure all the other factors, the social determinants to health are met when we're looking at COVID-19. And the ones that I've had an asterisk on, these are things that me and you can do to ensure COVID-19 doesn't continue causing the havoc. And for the benefits that are there, we make the best of it. Be aware that COVID-19 is with us. It is here, it is with me, and it is with you probably where you are. So you have to take extra measures. The best defense is be responsible at an individual level, for the people around you, and whoever comes close to you, you have to ensure you do the right thing. That is social distancing, hand washing, masking, and all that. Then acknowledge that governance and health system shortfalls, which gives you more load to carry, but it's what we have at the moment. So we have shortfalls in our government and self-structure. And because of those shortfalls, it's you who has to take responsibility, because when you get sick, it will be up to you. When you look at it in terms of even the political skirmishes, how another group of people are being allowed to hold public gatherings, others are not, the question that you need to ask yourself, they're not being allowed, and people are talking about it like it's a divisive thing. It's divisive, yes, it is, but the question is, would you risk your life? And if someone is doing the wrong thing and they're being let go with it, does it make it right for you to also do the same thing? So that is where we have to acknowledge that we have a system in our governance, we have a system in our health systems, and that means you have to take extra precautions as a person, as an individual at your own level. And once you do that, that guides you in ensuring you reduce the risk of transmission to the people around you. You hold that governance or the government system that is faulty to account by telling them what really needs to be done and being bold about it, because at a personal level, you know you've done the best you can. So that is on calling on the government to do the right thing. But at the same time, you look out for those in your vicinity. So those are the key things that we have to look at that point. Is it a maker or a breaker? If you ask me, I would say it is both. It is a maker because it has made us realize the shortfalls that are in our system. And now there is some kind of, however, it's not that much of positive response towards responding to COVID-19, but there is action that has been taken. And that action that has been taken is going to give us a way forward. And it's up to us to drive that action to ensure we achieve the ultimate goals of a robust and efficient healthcare system. That's a maker. For the people who have been gotten into business and are doing the good stuff they can to ensure people are responding, providing masks, providing sanitizers, and all that, they're getting something out of it. At least there's a business that's running and they can fend for their families. That is a positive of COVID-19. For some of us, you've had the chance to stay with your family for the whole 3 months or maybe 2. It's a maker because maybe you never had that kind of a time, but you've had the moment to spend time with your family, to bond with them. However, not in the best of moments, but you had that time. So you appreciate that. As a breaker, we've lost lives, for sure we have, and it's a painful moment realizing that someone you really knew dies of COVID-19, or even if not dying, they're in hospital, they're not in the best of states, and the anxiety that comes with it, it's a terrible thing. Realizing that our government and our healthcare systems are not at the best, and we keep being fed with rumors and bogus information, it's a breaker because you wonder whether your trust is, it's somebody breaking your trust, and you can't trust them anymore. And that is why probably as Kenyans, people are annoyed, people are angry at the system, and people are even willing to flaunt all the rules. But the question is, you're flaunting it to someone who doesn't care whether you do or you don't. So you have to take the upper ground and play according to your game. No, don't stoop too low to their server. So that is the most important thing. It's for you and me to decide and act accordingly based on whether it's a maker or a breaker. For what I've said, it's a maker and a breaker at the same time. You at an individual level, you know better and you can see whether we are moving in the right direction or not. And then if not, how do we get it to the right direction? If we're going in the right direction, how do we speed that movement and to get a better momentum towards it? The darkest hour of the night comes just before dawn. Thomas Fuller, that's a quote that I got about Thomas Fuller. It's not the best of moments, we are going through a lot, but the next phase will be better if we take action now. So let's do the best we can. So that's the end of the first session, and I'll give you a moment to share your feedback, questions that are there before we move to the subsequent one. Hezron, back to you.
So, David, thank you for that. And I'd like to ask our participants to ask questions that they could be having. So you can type them on the chat or you can raise your hand and you can ask. The floor is open for questions before we move to the next topic.
Maybe if there's none, we can go to the subsequent session, then people will raise the questions when we are done.
Yeah, that's okay.
Thank you. So moving on to the subsequent section, the second phase. US-Kenya Free Trade Area trade deal that is in the way and it's coming up. It will be good to us depending on how we take it up, and it might not be the best if we don't take action and do the right thing with it. As it said, every opportunity comes. What matters is how prepared you are to take that opportunity. So to look at the free trade area, the background of it, it's been a there's long-standing diplomatic relations between Kenya and US since 1968. So when Kenya was, there's a relationship, they were marking 55-year anniversary, that was in 2018. The president of US and Kenya, that is in 2018, they had a discussion on 27th of August and decided that there's need to establish a bipartisan relationship that would enable them to foster that relationship as two country states. And other than that, there's the African Growth and Opportunity Act, the AGOA Act, that was approved in 2000 under the Bill Clinton leadership. However, this is going to expire in 2025 after previous extension in 2015. It was to expire in 2015, but it was extended to 2025. If it's going to expire, then it means the trade benefits under the World Trade Organization and the Free Trade Area provisions would not work at this point. And then when you look at the free trade area provisions of the World Trade Organization, it's favorable for countries that are characterized as a lower income countries. And Kenya, as you all know, has moved from the low income countries to middle income country. So it therefore means any export that's coming from Kenya to any other countries, especially the ones that are going to be under a country of preference. For example, US is a developed country, they declare the terms of that trade. We are not going to get the benefits of that trade. So as a country, we'd be disadvantaged. So it's making it imperative, either we go to the World Trade Organization free trade area, which won't be favorable to us compared to the benefit that we are enjoying at this particular point under the AGOA provision. And beyond that, the other alternative was to have a tailored modality on a free trade area between the two countries, which makes it be Kenya has an upper hand or compared to what it would have had with the World Trade Organization provisions. So when you look at what the US has to gain, majorly not much, but there is much to be gained for them. For example, Kenya being a strategic country in East African community, it's going to give them access to the region. And if they have access to Kenya, they have access to all the other countries in the region. Two, when you look at the whole of Africa, the countries that set trends around how business operations deal in Africa, it's always Kenya, Nigeria, South Africa, and Ghana. So the other countries will adopt the trends based on what's happening in the Kenyan space. And therefore, having an influence in terms of the policy transformation, the business trades, trade deals, and all with Kenya, favors US in terms of their global vision, global agenda for action as a superpower in a country. So that is a benefit for them. On the other side, when you look at it in the Kenyan context, we want to grow and we need to enjoy the benefits in terms of the business trade, the business support, and the social support programs. For example, if you look at it in the healthcare space, a number of health programs have been funded by donor funds. And these donor funds, majorly you'd see there is the USAID, United States Agency for International Development. USAID funded a number of them. It's ranging from maternal care, newborn care, HIV, AIDS, PEPFAR, malaria management. So all these are benefits that are linked to the US social support to the developing countries. So that was the background of it. So what were the areas of the negotiation? Trade in goods and trade in services, then the intellectual property rights, including investment and other trade-related areas. So if those were the areas of negotiation that were being looked into, then what were the objectives? One, open markets with favorable terms of trade in compliance with World Trade Organization. Kenya benefiting from US foreign policy. Those are examples that the ones that we're looking about in terms of support, in terms of security, for USAID supporting social development programs. to establish safeguards and exceptions to protect Kenya's nascent industrial and agricultural sector. So it would enable us to protect our local industries. For example, there are some of the products that can come from the US, which would be cheaper compared to local production. But in this case, if we have a trade agreement, this can help us get better. Then we have increased inflow of direct US foreign investment into the country. We need investors in the country, and this trade deal would going to look into such. Market access for identified goods and services. Majorly for our case, it would be what products do we produce as a country? Do we have value addition services? And how do we ensure these products can be exported to the US? The major product that I know we export as a country is coffee and tea. So if we export our tea to the US and other countries, then this is an avenue that we can use to continue exporting. Because if you realize from 2018, 2019, it was stated that the greatest, most of Kenya's export, number 3, is the US, with up to 256 million US dollars in terms of revenue that was exported. Then it promotes Kenya's position as a transit hub and entry into Africa. That will be in the favor of the US, but also as a country, it creates employment opportunity, because if we have a transit hub and an entry point, then it means people will be required to support that hub, to support the line of work and even the transportation of goods. So that's a business opportunity for the country. Sorry. Then expand value chains, especially in production, value addition, and transit trade to create demonstrable economic benefit to Kenya. Provide technical assistance and capacity building, which will enable Kenya to participate in and implement negotiation outcomes. Ensure balanced outcome, trade in goods, services, and investment. Create framework for inclusion of interested EAC states. Well, if those are the objectives, where's health? And when I look at it in terms of where health is, we look at health and health system factors that are very critical. We have medicines, medical products, and technologies. We have health workforce capacity and technical skills. Health workforce capacity and the technical skills that they need to perform their job. Then we have global health needs, which are unmet or underserved in the current context. Sexual reproductive health services and rights have not been met as much. Mental health services are not available as we would wish them to be. Maternal care is a compromise somewhere. HIV/AIDS, there's the risk of stopping the PEPFAR funding. So we have to leverage on such kind of measures. So, and many more issues within the healthcare space. So if we look at the focus areas that were goods, services, and IP rights, then we look at it from angle of investment and social programs, then what's next for us? What's our play as a country in terms of ensuring we tailor these? We need to guide the discussions in terms of what are the provisions so that it doesn't come as a blanket cover for us as a country in terms of how will we get access to these healthcare services. So we don't leave it to the governance structure, the ministers and all that, the policy formulators. We know what we need. We know what issues are there in our healthcare system. If at all it's not factored in the current agreement, it won't be easy to factor it in the long term and even to ride on that wave when things are established and the final agreement is signed. The reason being, at this point in time, the major factors or the major concerns that have been highlighted have been on trade, tourism, agriculture. Health has not been mentioned as much, yet it's being as an implied outcome of the negotiations in the whole document that I've read. So if it's just an implied factor, then the question you need to ask yourself, yet it has been in the whole discussion that we've been seeing, there's so much that is happening in the healthcare space, and without health, we can't do trade. Without health, we can't continue into agricultural production. These are interlinked systems. So how do we ensure we have a health agenda and get integrated into the whole trade agreement framework? That is where we need every other individual, whichever forum you are, you hear there's discussion. Probably in the last week, I've seen the Cabinet Secretary for Trade Industrialization being invited, that's CS Betty Maina. She's been called a number of sessions to the TV stations, being asked questions about the free trade agreement and discussions that they're going on with. That is the point that we have to highlight some of the issues that are in the space. And different advocacy forums, professional associations, social movement groups and all that, bring these discussions. And then once they're in those discussions, they can be cascaded up into the ladder. And ultimately, some of them will see the light of day. That's for the best benefit of our health systems and us as individuals. Which areas can you leverage for improved access to quality healthcare services? You as an individual in your area of work, what aspect do you feel you can integrate in terms of, let's say, the medicines, medical products and technologies, the health workforce capacity and technical skills? Where do you work? And where you work gives you an avenue in terms of what needs to be improved. And how can we use this kind of an integration to ensure this free trade area helps you solve that problem? I can give an example in the current state. I'm a pharmacist, and as a pharmacist, I'm looking at it in terms of local production of medicines and medical products. We import over 70% with limited local capacity in terms of production, especially for branded products, the innovator products. Yet, our local production can sustain our market, and even our local generic producers serve the East African and even the Central Africa region. So what if we could play this game in a way that we integrate into the whole discussion with the CS team and all the trade and investment working group to ensure there is knowledge transfer, that is intellectual property rights, so that at the end of the day, there is room for knowledge transfer, that is capacity building, and at the same time, investment because they have offices that are in these countries, marketing authorization teams. Can we build a capacity to start local production? It might take a while, but at the end of the day, it will enable us to be independent rather than relying on them, yet their products are being sold in the market. So we can explore such kind of opportunities. You ideate, collaborate, and innovate. You have so many ideas. Even now in the onset of COVID-19, there are people who have been making ventilators in the local market. There are people who are making ambulances, the small ones and all that. So how do we integrate such kind of ideas and make them see the light of day? Because at the end of the day, you need funding, one. Other than the funding, you need somebody to support in production in scale. The US have the ability. As individuals in the local context, we understand our problems, we can create ideas. How do we use that within the framework of the intellectual property rights protection within the free trade area and support system to ensure they see the light of day and help our health systems? Then the knowledge transfer. When you're talking about employing healthcare workers and all, can we structure engagement with some of the universities in the US that can help in training of healthcare workers in the country? We can have such kind of negotiations being integrated into the whole system. Rather than waiting for a pandemic to import 20 Cuban doctors who we are not sure whether they deliver or not, how about we have an arrangement where our doctors can go get skilled, then they come back and train, and in the process it kind of forms an exchange program that serves the local need and the international need at the same time. And it builds our local capacity to a point that it's not like when the AGOA Act is coming to expire, we are looking for another treaty. Instead, we build a structure that we are able to sustain ourselves. We don't wait for an extension, or rather, we know we are able to. And it makes people want to be forming those alliances with us. Because at this point, if things don't work out, we lose out because we don't have the preferential treatment because we move from the low income country to middle income. So all the zero-rated tariffs and all that, they're not there anymore if we revert to the World Trade Organization free trade agreements. So these are concepts that we need to play. What's in it for health? Policy decisions are for people, and unless people are part of those discussions, whichever the outcome, it doesn't benefit its intended goals. So if you're not part of the discussion, it will never benefit you because it doesn't have your input in terms of driving what you really need, how it needs to be done, and once it's done, how the outcome is going to be implemented. So you have to be part of that discussion, and that is where we should start. Ask not what your country can do for you, but ask what you can do for your country. Thank you. So I'll send it back to Hezron as we are about to wrap up as well.
So thank you so much, David, for the presentation. Now we'll go to the question session, and I can see there's one here from Danielle, and let me just read it through. So I read that the virus immunity behaves like flus, where it only lasts for 3 months after exposure to the virus. It's also a well-known fact that even after the approval of a virus, it's going to take months before it's available to us. In brackets, if at all, it will be enough for everyone. So in this light, as a healthcare worker on the ground, what would be the ideal situation? Prolonged lockdown or opening up and relying on guys developing herd immunity as soon as possible? So what's your take on that, David?
I think on that aspect on approval of a virus, I think that is approval of a vaccine. Right, Daniel? I think it's
Hi. Sorry, what? What did I type? Yeah, vaccine. Sorry. I was typing quickly.
It's okay. So the virus immunity.
Can you hear me?
Yes, we can.
Hello.
Hello. We can hear you. Yes. So this is the point. The immunity is not as confirmed as much. There are people who perceive that once you've been infected and you develop immunity, the antibodies are formed, then you might not be able to suffer from the virus again. However, there's emerging evidence that it's not working as such, and therefore, there is risk of infection and even getting sick again once you're infected. So that is one thing that is out, the immunity aspect of it is out of the equation of the response mechanism, unless there's emerging evidence that will prove that it's workable. That's one. Two, when you look at in terms of the availability of a virus, a vaccine, it will take months for it to be available to everyone for use, because we need the clinical evidence in terms of if its efficacy in a population of people. So do we have that data? No, we don't. So therefore, any product that is being made available, it will have to go rigorous testing among individuals, among populations to prove its efficacy. So that will take longer, or might probably even a year or so, as it's stated that maybe up to February 2021, that's when we'll have a vaccine, and that vaccine will be now out for trials and use in populations. It might be in small quantities, and that's why even countries are forming pacts and all. For the African context, if you guys have been following some of the news, there was the establishment of the African Medical Supplies Platform. That was going to form a leveraging platform for African countries to mobilize resources and forces to be able to buy in bulk as well, rather than losing out against higher bidders. We don't know how that will turn out. It might or it might not. When you look at it in terms of the other aspect of it, in terms of opening up and letting people develop herd immunity as well, or lockdown. Well, lockdown, we had a lockdown. Did it achieve its outcome? People have come out of the lockdown worse than where they went in, with not much that has happened. At this point, I want to give an example of a country that I'm sure most of you have been against their response and all. And to me, their response in a way forms a basis for what we should be looking at. Tanzania Magufuli, when COVID was reported first, he had concerns about the whole situation. He didn't have a scientific argument as to why the things were going the way they were, which is for sure not the right way to approach it if it is a medical concern and we have scientific evidence behind it. That is one. Two, when you look at it in terms of the response, what would he have done differently? There's nothing that he would have done different, because if he initiated a lockdown, it would be in the same mess that we are in Kenya, where we have a skyrocketing cases, people are broke, people are stressed, and nothing is working in their lives as much. On the other hand, in his case, we are at the same level, just that we are more broke. For their case, people didn't go into lockdowns, people have been working, at least they can afford a meal, even with COVID-19 in this situation. So would I recommend a lockdown? I don't think it's necessary to have a lockdown unless we have a clear plan on how do we contain the new infections. And once we contain the new infections, how do we ensure people are able to cope with their social livelihoods? Do we have social support systems for them, the social support network, the social welfare? Do they supply food for them? Can we do it? I don't think Kenya has the capacity to do that. And even if we did, according to our nature as Kenyans of having to get a cut out of everything, it might never get to the very people who need it. So is it necessary to have a lockdown? No, because Kenyans are used to every Kenyan for themselves, though that should change. So that is one, we don't need a lockdown anymore, and it's not going to serve its purpose. Two, the issue of testing and all that, they're not helping, because once you've confirmed positive, You either go stay home or you continue with your life. So life is back to normal. The only thing we do, reduce the risk of exposure or infection as much as possible, because you don't know how the virus, if you're infected, will manifest in you. And you don't know if you're infected, how when you transmit it to someone who is close to you, it will manifest in them. So you have to avoid the risk of infection. Not that the testing and anything will improve your outcomes, because it's only showing you that you're positive, full stop. Then after that, not much is going to be done. So we have to do the responsible thing, but you don't have to compromise on other individuals' livelihoods or in the name of trying to cushion them from the impacts of COVID-19. I hope I've answered you.
Yeah.
Thank you. Then we have Anne. We can have our own instead of importing. Each person has a role to play without attachment. Thank you, Anne. So we have a role to play. And the question is, how are we going to play that role? I know where we are starting, we are not at the best position, but with time, if we look at the opportunities that are out there, we look at the avenues that we can create to drive a common advocacy agenda. And other than the advocacy, now we look at which framework, which structures are in place that we can implement these ideas with. Can we, for example, let's say for the free trade area in the US-Kenya agreement that is coming up, if an individual, let's say from my pharmacy aspect, I can approach a US-based company, Pfizer Pharmaceuticals, they operate in Kenya, they're from the US, and tell them we now want to have intellectual knowledge transfer, build capacity for local production. They start a farm. It might be the smallest level it can be, but it gives us room to grow. And when they are supporting the local production, we are at a better position. We're opening market for them to produce in another country as a US company, but also having the local production, lowering the cost of production. People who are going to work in that industry will be Kenyans because it's in Kenya. So how many jobs will we have created? Rather than having an investment plan without knowing what really needs to be done. We need to think like business people at this point. And that will be very important. And then the other thing that I realized that we need to look at as Africans, as Kenyans, is when developed countries make trade agreements and negotiations, they're negotiating with a company in mind behind it, driving that agenda. For example, you realize, for example, when we're talking about data policy, data privacy, digital policy issues and all, the biggest companies are behind it. You find Amazon, you find Apple, you find Microsoft. They have had a discussion with the policymakers and told them the implications that it would have in their own companies and in terms of their business projections. So the policymakers and the government is advocating with something in mind in terms of how it's going to have an implication on their companies, their companies and the welfare of their people. In our case, our politicians go into negotiations with the implications of their interests and what the higher power wants. That is the developed country that making the negotiations done. So are we losing or gaining? We are losing and we'll keep losing until we change our mindset and look at it in terms of what value we can create and how sustainable it will be. Thank you so much. Hezron, back to you.
Thank you so much, David. And have you responded on, there's a question here that was asked, what's your take on COVID being a systemic rather than respiratory disease?
A systemic rather than a respiratory disease? I have not seen the question, but let me just answer because you've said it. It is a respiratory disease with systemic manifestations. That is from the evidence that I've read. If you look at it in terms of the people who have had severe complications, they're not able to breathe. And their inability to breathe compromises the organ functions, because if you can't transmit oxygen to your essential vital organs, then it's not going to perform. And that is where now the systemic manifestations are rising. That's where we have acute kidney injury, we have cardiac failure, myocarditis, we have brain, I think there was something about the brain being also compromised as well. So all these complications that are arising, I would say it has the respiratory component as the primary focal area. Then post that, because of the impact of respiratory system in terms of the overall functioning of the body, the other complications manifest. So depending on the evidence that we have, most of it hasn't been the systemic as much. It has been respiratory with systemic complications and manifestations. Thank you.
So I guess now we are at the end of the session, and I'd like to thank you so much, David, for the insightful session. And I believe for all participants, we've been able to pick something out of it. So we appreciate you for being there till the end of the session, and we're looking forward to having you in the coming sessions from next Sunday. So this video is being recorded and it will be shared to our social media pages where you can access it. So I think if there's nothing else, we can end now. Is there anything else, Dr. David?
No, thank you so much. And I really appreciate it.
Okay. Thank you. So have a good evening and a fruitful week ahead of you. Thank you.